Dr. Rajeshwari. Dr. Rajeshwari has also done MBBS and MD from Madras Medical College, Chennai, and she is a holder of DM Rheumatology from the same college. At present, she is Associate Professor of Rheumatology in Government Kilpauk Medical College, Chennai, and her rheumatological interests are vasculitis and lupus, and she has many awards in her kitty. One for the mainly poster presentations in the national meetings, and she has a few international presentations to her credit. She was a guest speaker many times in China on lupus and vasculitis, as well as she has presented poster and a presentation in United States of America also. So, Dr. Rajeshwari, please.
Good afternoon to everybody. It's my duty to thank the organizers, the Chandray group, Dr. Chandrasekhara, Dr. Renuka, and the absentee Dr. Dharmanand, and the whole Chandray group. I wish them success in all their future endeavors, and I'm privileged to be here for the first decade function. And I will try to do my level best regarding this most challenging topic. It is not a single disease which was spoken. My former speakers were privileged to have a single disease addressed. I'm not so lucky, and things have been very challenging. All of you know vasculitis is very demanding, challenging, unfathomable. So I have just chosen a few vasculitis which have seen some advances both in diagnosis and management. Few vasculitis which we have not paid importance to previously, which we should have some knowledge of. And I will try to rush through the slides regarding the trials because they may not be as interesting to this present audience, but you should be aware of the names of the drugs. So I will start off straight away without wasting much more time. And I thank the chairpersons for the kind words also. So first, we don't have a definite classification or diagnostic criteria for the vasculitis. It was way long in 1994, the Chapel Hill Consensus, and only now in 2010 have they thought of having a new diagnostic as well as classification criteria for vasculitis, and it should have been over in 2012. I've just got a report about it, and they have just changed it. Previously it was large vessel, medium vessel, and small vessel, and that was it. And then the other vasculitis, according to the Chapel Hill. Now they have addressed anchor vasculitis. They've included that also as well as one group, and they've minimized the small vessel vasculitis to hinox-Schönlein purpura, essential mixed cryoglobulinemia, and the urticarial vasculitis. And then they have addressed another group, vasculitis that do not address to any vessel as such, like Behçet, Cogan's, unclassified, and primary angiitis of the nervous system, which we have never addressed properly at all. And we have lost our diagnosis in diagnosing many of these angiitis of the nervous system. I'll be concentrating a little more on these unforgotten or forgotten disorders. So, lot of advances have been made in the anchor-associated vasculitis. They are, as all of you know, Wegener's. The name has been changed to granulomatosis with polyangiitis, and then the MPA, or the microscopic polyangiitis, and the Church-Strauss. The difference between Wegener's and Church-Strauss is Wegener's has both an intravascular as well as an extravascular granuloma, whereas Church-Strauss has mainly an extravascular eosinophilic granuloma, necrotizing granuloma in the histopathology. MPA, in South India, it's not seen much, whereas in the North, it has been addressed quite a lot, and so usually associated with hypertension. It usually involves the small vessels. It comes under the group of the pulmonary renal syndromes. This is a picture of Wegener showing the episcleritis, and the first picture down shows a nodule, necrotizing nodule, which has later transformed into a lung abscess. Of course, the mortality rate is very high for these patients. ANCA has been known for 50 years, but the ANCA-associated vasculitis, the association has been known only since 1985. Dr. Renuka has described very aptly about the patterns in the IIF, the granular, cytoplasmic, atypical pattern, perinuclear pattern, and then when we have a cytoplasmic plus perinuclear, it's also called as an atypical ANCA. Of course, all these have to be correlated with the clinical findings. Never treat a patient just by an investigative procedure, and don't unnecessarily ask for an investigative procedure and then break your head about that, because the patient is going to come back to you forever asking, oh, my ANCA is positive, my ANA is positive, what should I do, and they're asymptomatic. You and the patient are going to spend sleepless nights. Of course, this is a pathogenesis of ANCA. I won't go into the detail. Only thing, it's antibody-dependent cell-mediated cytotoxicity. And then, some unforeseen antigen, and then the neutrophils are activated, TNF-alpha, and then you have the interferons, and then you have the endothelium as well producing the PR3 antigen. The cytoplasmic granules come out, and then the complement takes part, destruction, oxygen-free radicals. This is the ELISA. She has described it aptly. This is a first generation direct ELISA, neutrophils containing the granules, test serum, and then you have the antibodies, and then the anti-human fluorescent antibody, and then that shows the immunofluorescence. So we have 3 generations of ELISA, the first, second, and the third. They have been developed over periods of times. She has already discussed about the line immunoassay, the fluorescent enzyme immunoassay. Of course, the chemiluminescence showing both MPO, PR3, as well as anti-GM. It's a boon now. The second generation is the best as of today. As a clinician, it's a capture ELISA, which has an increased sensitivity to PR3 and increased specificity to PR3 as well as MPO. The third generation is the anchor ELISA, where the antigen is linked to a peptide linker. This is very useful in limited disease, showing PR3 with an increased sensitivity to PR3. This is the anchor ELISA. This is the carrier, this is the antigen, and this is the carrier. This is the linker peptide. The newer advances are, we now have an automated pattern recognition, and you have a direct non-competitive ELISA also. All these years, only native antigen had been used. Now we have recombinant PR3 also, with the His tag acting as a linker peptide to the recombinant protein. And of course, she has dealt in detail about the biochip technology. The advantage of this is you have both immunofluorescence as well as ELISA incorporated into a single assay, which is going to be very rapid and very useful for the clinicians. It's very useful in the diagnosis of new ANCA-associated vasculitis and the Goodpasture syndrome. And when we need a rapid test and a rapid interpretation, we can always use the capture assays, the ELISA-2. What's the role of formalin-fixed IIF? All these years, as a DM student, I've been taught that the ethanol fixed is the best. But now the formalin fixed again is coming into the picture, because certain anchor antigens like the HLE, which can diagnose drug-induced vasculitis, or the Goodpastures versus, it can differentiate a Goodpastures versus cocaine abuse, or the bactericidal permeability increasing protein. When the PR3 cannot be confirmed, this BPI anchor will show a C anchor pattern. And of course, to rule out Goodpasture syndrome, it is useful. And for a posse-immune focal necrotizing glomerulonephritis, we have the LAM2. All these can be assessed by the formalin indirect immunotherapy. And occasionally in biopsy-proof patients. So never go only by anchor testing, as I already said. So these are the questions to be addressed. Is it possible to screen by antigen-specific assays instead of indirect immunofluorescence? Are second and third generation specific assays mandatory for the diagnosis, or antigen-specific assays to be calibrated? Is there a place for antigen-specific assays other than MPO and PR3? Is there still a role for IIF? Are formalin-fixed neutrophils still to be used in IIF? Should rapid testing be available in interpretation of all tests? And is it manageable to present results as likelihood ratios for test intervals? Likelihood ratios always indicate the positive probability and the negative probability. More than one, the disease becomes more positive. the lesser than 1, it becomes negative. So now coming to the treatment, we have a lot of biologics. All of you must be saturated with my former speaker's speeches. So I will just address few of the drugs: TNF-alpha, IL-1 anakinra, IL-2 daclizumab, IL-6 tocilizumab, alemtuzumab against CD52 on the T cell, given up, abatacept, not much tried, rituximab, yes, there are trials, and new addresses IL-17. Now, before treating a patient with ANCA-associated vasculitis, previously we used to individualize the treatment for all these vasculitides. And of course, even today, every patient's treatment is still individualized. What we are going to follow is only the guidelines. The only advantage during the last 1 decade is a unified approach has been proposed for these ANCA-associated vasculitis. So they have categorized these patients into localized, early systemic, generalized, severe, and refractory. And depending upon this clinical presentation, you give the drugs. Localized, one system, usually upper respiratory. Early systemic, involvement of multiple systems without any vital organ failure. Generalized, impending vital organ failure with the creatinine less than 5.6. And if it's going to be severe, the creatinine levels are going to be much higher. Refractory, of course, refractory to conventional therapies. So what are the drugs that have been used during the last 1 decade? Cyclophosphamide, it can be given as an oral or a pulse therapy. Oral 2 mg per kg per day. Pulse 15 milligrams per kg every 2 weeks. Remember, every 2 weeks. It's not like the pulse therapy NIH protocol of SLE. And then we can reduce the dose. I'll come to that in the next few slides. Azathioprine to be started at 2 mg per kg per day. Methotrexate up to a maximum of 25. Prednisolone either oral or pulse. Oral 1 milligram per kg per day. And then the dose reduction over a period of 3 months should come down to 12.5 milligrams per day. And then over a period of a year, it should be a maintenance dose of about 10 milligrams. Mycophenolate 1.5 to 2 grams per day. These are the multiple trials that have been tried. Cycloziram, cyclophosphamide versus azathioprine. They tried to replace cyclophosphamide with azathioprine. Azathioprine was as good for maintenance of remission. NORAM trial, they tried methotrexate with cyclophosphamide. Methotrexate did work well for remission but did have higher relapse rates. Cyclops trial, oral versus pulse cyclophosphamide. The remission rates were equal in both, but the relapse rates were higher in the pulse therapy. MAPEX trial, methylprednisolone with plasma exchange. Plasma exchange did a wonderful job as far as the renal recovery was concerned. Rituximab, rituximab in refractory vasculitis, ANCA vasculitis, it did not work very well. The side effects were more. MySic, mycophenolate mofetil versus cyclophosphamide, still in the process of being recruited. Pexivax, a double crossover with steroid and plasma exchange, still being worked out. So the standard therapy will be prednisolone, as I told in the previous doses, to start off with cyclophosphamide. Next stage, maintenance of revision, azathioprine with methotrexate. Add-on drugs will be IV pulse, plasma exchange, IVIG, or TNF-alpha blockade. So our main aim is to reduce the cyclophosphamide exposure, so there are alternatives to it. You can switch to an alternative. You can use an IV pulse instead of oral, or you can go to an alternative induction. So cycloziram, this is a picture showing cyclophosphamide with azathioprine. Both are equally efficacious. Methotrexate versus both are equally efficacious, but methotrexate relapses are more. Pulse versus oral cyclophosphamide, the pulse therapy showed more relapses. All patients who receive standard therapy with oral cyclophosphamide prednisolone receive 7 plasma exchanges or 3 grams of methylprednisolone, and the plasma exchange worked very well. For refractory disease, the RAVE trial used rituximab. This showed a good result. 64% achieved remission, as effective as cyclophosphamide, and it was also useful for alveolar hemorrhage. No significant differences with regard to adverse events. But the rituximab showed a different picture. Serious adverse events occurred in the rituximab group. So it was not superior to standard IV pulse. Other agents, infliximab, very small trials, thymocyte not used, IVIG more appropriate and where other therapies are contraindicated, especially if severe infection is present. This is a new trial with infliximab. This is given up. This is in the trial stages. For remission maintenance, azathioprine is as good, less aggressive, cyclozeram. Improved trial, international mycophenolate mofetil to reduce outbreaks of vasculitis. It did not show any difference. But the incidence of infections in the mycophenolate was slightly more. Etanercept has no role. Remain is an ongoing US trial. Leflunomide small group did show some superiority over methotrexate. So, coming back to the different managements, for the limited group, we use corticosteroids or methotrexate or azathioprine with topical therapies. For early generalized, cyclophosphamide with steroids, methotrexate with steroids, mycophenolate with steroids, steroids being the back arm. Active generalized, cyclophosphamide with corticosteroids. Severe, again cyclophosphamide with corticosteroids with plasma exchange. For refractory cases, we use rituximab. For remission, azathioprine, mycophenolate, or leflunomide with low-dose steroid. So what are the EULAR recommendations? They should be managed in centers of expertise. Anchor testing should be performed. A positive histopathology is mandatory. A clinical assessment, urine analysis, and basic laboratory test at every visit is absolutely essential. Patients should be categorized according to the severity of disease. A combination of cyclophosphamide, either oral or intravenous with glucocorticoids, is required for induction of remission. And then for maintenance, as I said, it should be methotrexate or azathioprine or other alternatives. High-dose steroids mandatory when necessary. Plasma exchange for severe renal disease or alveolar bleed. Remission maintains with low-dose drugs, as I already said, and other alternative immunomodulatory have been tried. Remember, thromboembolic disease is very common in anchor-associated vasculitis, so this should be addressed, and it does not require any anticoagulation as such, and aggressive management is more than enough for these patients. Alveolar bleed, again, is very, very common, especially in MPA, so aggressive therapy, once again, is mandatory. So for induction, prednisolone, IV pulse cyclo, metho, rituximab, mycophenolate, plasmapheresis. For maintenance, again, in the lower doses. And remember, for maintenance of remission, the treatment should be for at least 24 months before you call this disease in remission. Now we'll go to better topics, more interesting ones than these autoantibodies. I will deal just with a few aspects of advancements which I thought was essential. I will address large vessel vasculitis and small vessel vasculitis and certain other diseases which are forgotten or not seen, which are uncommon, may be common, and maybe we miss them. So this is giant cell arteritis. You see the dilated tortuous tender temporal arteries. You see the eye involvement in the early stages, the angry looking fundus, and then you see the histopathology here with the disruption of the internal elastic lamina, and you see a few giant cells there. That is giant cell arteritis. This is Takayasu showing the ICA, obstruction internal carotid, with an infarct over there. And this is this is my hand-on diagram just to distinguish the internal elastic lamina in Takayasu is an acellular one, and of course all three layers are involved, whereas in giant cell arteritis it causes disruption, whereas in Takayasu it starts from outside, in giant cell arteritis it starts from within, but in the final stages both resemble each other. So what are the new concepts in giant cell arteritis? So You may ask me, how do we diagnose? Of course, clinical diagnosis is important, elevated ESR, CRP is important, all those are old diagnostic tests, and still the controversy remains. Is it ESR or CRP? Can the ESR be normal? Yes, it can still be normal, but then what's going to happen? The patient can suddenly become blind. They can go in for irreversible blindness. So it's a clinician's duty to make a quick diagnosis and treat aggressively even before you start investigating sometimes. So you can do an ultrasound Doppler, which is going to show a dark halo sign over the temporal artery, showing the thickness and the inflammation. A biopsy can be taken even after instituting treatment, high dose of pulse methylprednisolone or high oral dose prednisolone. So they have suggested in 2010 in one paper 60 milligram per day for 2 days, then 50, then 40 for 2 days, and then you can taper once clinical and lab improvement occurs by every 1 to 2 weeks, decreased by 10% of the total dose. If there's impending visual loss, go straight ahead with the pulse methylprednisolone therapy. Never wait. You can save a patient's vision. If it's going to be an isolated polymyalgia rheumatica alone, with severe incapacitating neck stiffness, shoulder stiffness, hip girdle stiffness, and of course now we have new signs like tendinitis, wrist arthritis, and an elevated ESR, low dose prednisolone is enough. But if they are not going to respond, go ahead and treat as for GCA. And in GCA, it's mandatory that 81 milligrams per day of aspirin should be given to reduce the cranial ischemia, as intracranial manifestations can occur. In fact, today's concept is Takayasu and GCA are nothing but two ends of the spectrum of a single disease. What you may think is Takayasu initially may turn out to be a GCA later on. We have to keep all these changing trends in mind. Other drugs, immunosuppressives, nothing is inconclusive except tocilizumab, which has worked out well for both the large vessel vasculitis. As far as Takayasu is concerned, all of you know about the ASIA criteria. There's nothing new to talk about the criteria. But still, as far as investigations are concerned, rapid strides have occurred in the last 1 decade. We have the MR angiogram, we have the multi-slice, 64-slice CT angio, we have the PET scan, which is very expensive, but we can just look at it now. We have to maybe wait for the common patients for it to be accessible. And of course, the cost-effective ultrasound Doppler, of which I have done quite a lot of work, and I have found it useful in my follow-up patients for over 10 years, the intima medial thickness by ultrasound Doppler in the most accessible common carotid arteries, especially the distal part of it, and it has been working out fairly well with the addition of statins in these patients. So that is an MR angio showing an infarct. This is an MR angio showing the left renal artery stenosis, and that's a CT angio showing a thrombus, and then you see the calcification. In MR angio, the calcification will not be seen, but the advantage of an MR angio is the early vessel wall edema and the thickness which can be picked up in an MR angio. This is an MR angio showing the edema, and there you have an aneurysm with a thrombus. This is a CT angio. MR angio doesn't pick up the peripheral vessel, so a CT angio is far better. This shows a block in both the common iliacs. This shows a multiple aneurysms, coronary, abdominal aorta, left renal artery thinning, and this is a most common differential diagnosis, a periaortitis. This is a CT angio showing the fibrosis surrounding the aorta, often mistaken for Takayasu. And now we come to the fluorine 18 FDG PET glucose, the fluorodeoxyglucose, which shows the glucose metabolism. In inflammatory tissues, the glucose metabolism increases. So in these areas, this PET, the 18 fluorine, will pick up, and in Takayasu, you can see the circumscribed, linear, uniform radio density, and this is over the carotids. Whereas in atherosclerosis, it will be seen as a patchy area. It can be used to assess disease activity. The only thing is it costs 20,000 rupees for a single area. So imagine it's a large vessel disease affecting all the areas. So it's going to be very, very expensive. And this is the ultrasound Doppler showing the IMT. I have not shown you a carotid picture. Instead, I picked up a superior mesenteric artery. In skilled hands, even the abdominal aorta, even these vessels arising from the aorta can be picked up, showing the increased intima media thickness. That's a superior mesenteric artery. So, treatment for Takayasu, what are the recent advancements? All of us know that steroids have to be used, and we are using methotrexate, and in resistant cases we have tried azathioprine cyclophosphamide. I have tried mycophenolate mofetil. It works out very well in method-resistant patients, whereas as far as biologics are concerned, see these pictures. See this data, 50 milligrams twice weekly. It's not the conventional dose which has been used for rheumatoid or for other diseases. It's a double the dose, and infliximab 10 milligram per kg to obtain a sustained remission. Tocilizumab has been found to be very, very useful, even for mycophenolate mofetil resistant patients. I have a single patient who's been with follow-up on me who's received 12 doses of tocilizumab, and now he's on MMF therapy, and he's doing extraordinarily well. He's even recanalized his almost 90% occlusion of the carotids. But that's only a single case report. What about surgery, the neglected area and large vessel vasculite? What have been the advancements? What is the indication for surgery? You do an angio. If it shows critical ischemia, no infarction, no collaterals, go for a bypass. It can be an aorta carotid, it can be a superficial temporal MCA, subclavian to MCA. There are high flow bypasses with ICA, ECA, CCA, all to MCA, or an MCA to the posterior circulation artery. Before that, you have to identify the ischemic salvageable penumbra. For that, you have to take the time between the first arrival of contrast in the brain and its peak concentrate, that's the time to transit, the median transit time or the average time for the blood to travel through a volume of the brain, the cerebral blood flow and the cerebral blood volume. So the penumbra will be increased MTT with normal cerebral blood volume plus decreased cerebral blood flow. These are the ideal patients. So ultimately, monitoring of therapy should be clinical, supported by measurement of inflammatory markers. Use of low-dose aspirin mandatory in GCA. Reconstructive surgery for Takayasu should be performed in the quiescent phase of the disease and should be taken only at expert centers. Behçet, neglected disease, misdiagnosed. So you see the array of pathogens or the immunopathogenesis, the array of cells that are included in Behçet. So this itself includes all the vasculitis put together. It can occur with any manifestation like syphilis and HIV, arteries, veins, any organ can be involved in Behçet. This is a pathogenesis, unknown HLA-B51, unknown antigen, exogenous, triggers off the danger signal here. And then you have the neutrophils, the oxidative burst, both ADCC, the antibody-dependent cell-mediated cytotoxicity plays a role, all the interleukins are activated, endothelial disruption, and the new cytokines are Th1 and Th17 here. This is a transverse venous sinus thrombosis, this is a arterial hemorrhagic infarct. So both arteries and veins can be affected in Behçet. Till today, we did not have a protocol, a set protocol for management of Behçet. So I just took this algorithm which was published in 2011. So major vessel involvement, if there are aneurysms or occlusion, go for immunosuppressive, cyclophosphamide or corticosteroid pulse. Otherwise, go for an urgent invasive repair. If they respond to this, maintain with the maintenance dose of other immunosuppressives. If they do not respond, go for invasive. For DVT, go for corticosteroids with azathioprine and aspirin. Central venous, go for aggressive therapy with cyclophosphamide and steroids. For visceral, again, it's going to be cyclosporin A, azathioprine, immunosuppressives with aspirin. No response, go for cyclophosphamide. Again, no response, go for biologics. Relapse, go back again. What are the biologics that have been tried in Behçet? Infliximab, etanercept have a role in most of the organ manifestations except skin pathogy where only infliximab works, and for intestinal manifest inflammation it's infliximab, and parenchymal CNS it's infliximab. Otherwise, for all the others, both the biologics work well. Kawasaki, Remember, it's not only an infantile disease, it can occur even in adults. Okay? It can be an incomplete Kawasaki which can present with gangrene or even CNS manifestations in adults. So, after giving the traditional treatment with IVIG for Kawasaki, especially in children, if they do not respond, what are the risk factors that they are going to go in for a coronary artery aneurysm? A fever, increased CRP, decreased hemoglobin, decreased platelets, decreased sodium, males less than 1 year of age. What do? Go ahead with an angio. We now have an intravascular ultrasound. We have a transesophageal echo, MRI. We have an ultrafast CT now. Remember, silent lesions can persist even up to 30 to 40 years of age. So all your young infarcts today, it's mandatory. They should have been screened for an antecedent Kawasaki when they were young. So the CNS manifestations, I don't think any of us really know till I went into the details of the CNS manifestations of Kawasaki. It can manifest like an aseptic meningitis, a meningoencephalitis, an ischemia, any type of infarction, a subdural effusion, myoclonic seizures, hemiparesis, and of course moya. We've never heard of that. It should be here in our country, only thing we are not diagnosing. But the deceiving features will be the sterile pyuria, CSF pleocytosis, the rash mistaken for exanthematous fevers, cervical lymphadenopathy mistaken for tuberculosis. So what do? All these years we've been taught that high-dose aspirin is mandatory during the acute phase of Kawasaki. Now it's a big controversy. Is it really essential? Or do we start off just with an antiplatelet dose, 3 to 5 mg per kg of aspirin per day for Kawasaki? Because the high dose has not been found to be really much useful. Corticosteroids were banned. Now they are back with the bang into the picture. Infliximab, yes, it's doing a wonderful job. It prevents coronary artery lesions. Abciximab is used to prevent thrombosis. Plasmapheresis, exchange, and other immunosuppressives with the addition of statins have played a good role in Kawasaki. And for stenotic lesions, they've tried percutaneous rotational ablation. Henoch-Schönlein purpura, commonest, neglected because self-resolving. There are CNS manifestations to Henoch-Schönlein. This is adult, that is a child. Of course, IgA is mandatory. Renal lesions are a controversy always. How to be treated? Usually it's a self-limiting disease in children. Renal lesions, wondering whether to use steroids or not. Now they have found that using early dose of high-dose steroids in the early phase can alter the renal disease. It cannot prevent it. It can just alter the course. Usually it's a mesangial-proliferative. We are lucky if we get a mesangial-proliferative. But if they go for a DPGN, then treatment has to be aggressive for these people. For cerebral HSP, corticosteroid, cyclophosphamide, with a Guillain-Barré-like manifestation, you have to go for IVIG and plasma exchange. For refractory cases, the new therapy is leukocytopheresis. Mixed cryoglobulinemic vasculitis, it's always HCV or HPSAG. Type 2 is common in collagen vascular disorders. See the gangrene there, see the recalcitrant purpura. So this is one area where rituximab has done a wonderful job, especially for the type 2, 375 milligram per square meter weekly for 4 weeks. Of course, they go in for a viral flare. You may ask me, what will happen to the RNA levels when they escalate? Then we have to combine with antiviral therapy with PEG interferon and ribavirin, the full course of the antiviral drugs as well. Now I'll concentrate a little bit on primary angiitis of the nervous system and how it has to be differentiated from reversible cerebrovascular constriction syndromes. This is a CNS vasculitis with a multiple hyperdense areas, primary CNS. This is a classical PAN, systemic vasculitis presenting with a CNS picture with an aneurysm in the splenic artery, livido, gangrene, and then of course the Barbara-Ansel lesions. This is again this is a reversible cerebral vasoconstriction syndrome showing an infarct as well as a hemorrhagic infarct as well as an ischemic infarct. It's a reversible syndrome. It's reversible within 6 to 12 weeks, occurs more in females, and it has to be differentiated from an angiitis. Here the CSF will be normal. There will be diffuse areas of multiple stenosis and dilatation which should resolve within 6 to 12 weeks. Biopsy does not show any changes, whereas it's exactly the opposite for a GACNS. There are CSF changes, biopsy shows granulomatous angiitis, and it can be an infarct, it can be a bleed, it can be multiple stenosis, it can be bleeding aneurysms, anything can occur. And remember, for RCVS, the infarcts occurs in the watershed or the border zone, and the hemorrhages occur in the parenchymal or the subarachnoid zone. For an RCVS, a high probability angiogram shows a reversibility. There are no specific lab tests. ESR, CRP can be normal. You have to differentiate it from other states like infections, hypercoagulable emboli, and drugs. Whereas in an angiitis, you have an aseptic meningitis, you have a pleocytosis, but the glucose is normal. There are increased proteins and immunoglobulins, oligoclonal bands are seen, and of course you have to screen for infections as well. And of course pathology has to be done, and these have to be ruled out. Treatment, cyclophosphamide with glucocorticoid for 3 to 6 months. Azathioprine, methotrexate, MMF have been tried. You have to do a serial MRI every 3 to 4 months. Prophylaxis for pneumocystis and osteoporosis have to be given. For systemic vasculitis, that is secondary vasculitis involving the CNS, like PAN, lupus, there the treatment differs slightly. You can use infliximab. Rituximab has been very useful in neuropsychiatry lupus. For RCVS, the treatment is totally different. You have to use calcium channel blockers, only a short term of glucocorticoids, magnesium sulfate, nimodipine. Only in severe cases you use cyclophosphamide. Sometimes they can go in for spontaneous remission. We should not forget children. They have adopted, even in 2006 itself, the PRESS EULAR criteria. Their GCA is not seen very commonly, so among large vessel vasculitis, they've included only Takayasu. For medium vessel, they've included childhood polyarthritis, cutaneous PAN, and Kawasaki. For small vessel, they've included only Wegener's and Church-Strauss. And for non-granulomatous, MPA, Hinox-Schonlein, isolated leukocytoclastic vasculitis, and urticarial vasculitis. Other vasculitis, you have the whole group, the Behçet, the HPSAG associated PAN, associated with connective tissue disorders, nervous system vasculitis, and Cogans. My eyes popped out while preparing the slides. Have yours done so? Thank you for your patient listening.
Thank you, madam. The case is open for discussion.
So thank you, Dr. Rajeshwari. Thank you very much.
Thank you.